Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non physician practitioners. I'm your host, Dr. Rebecca Bernard. Podcast listeners are already well aware of the differences in education and training between nurse practitioners and physicians. In fact, a new NP will have about 3 to 5% of the training of a new physician. Despite this vast difference, advocates for NP independence continue to insist that patients can get the exact same quality of care from an NP as from a physician. Some of the most compelling voices to truly speak to the differences in knowledge and education come from people who have experienced both worlds. Dr. Denise Weiss was a registered nurse before becoming a family nurse practitioner and then a physician. Dr. Weiss, welcome to the podcast.
Glad to be here.
It's so great to have you. I cannot wait to hear about your experiences. But why don't we start out by having you share a little bit about your nursing journey?
I had always wanted to be a physician, but in the 90s, when I was starting my path, just got discouraged by the length of school, like most people do when they're young. And so decided to become a nurse. I started out as an associate degree nurse, which is a 2-year program. And then while I was working, I finished my bachelor's in nursing, which is the 4-year nursing degree that we see most frequently now. And then I worked as a nurse for about 3 years in a variety of settings in the hospital. And then I started my 2-year master's of science in nursing at the time, which was the route to become a nurse practitioner. And I chose the family nurse practitioner route. And then I worked as a family nurse practitioner in a family practice physician residency program for about 3 years before I made the decision to go back to medical school.
Before we get into all of those details, I want to take us back to when you were first entering into nursing school. And can you share a little bit of the differences between getting an associate and getting a bachelor's in nursing?
Yeah. So in the associates program, it's very, I would say, accelerated, very abbreviated. But the biggest difference I would say is the associate degree nursing program. I learned a lot of the technical skills of nursing and actually felt like I was a very good bedside nurse based on the skills I got in the associate program. It's actually unfortunate that those programs are not as abundant as they used to be because they were really great ways to get good bedside nurses that had good hands on skills. My bachelor's program, I really didn't learn any new hands-on techniques or skills. It mostly was research, nursing theory, care plans, a lot of what I would call just basically book work, administrative type of stuff, public health classes, maybe a little more critical care coursework, but certainly no more technical skill based type of thing. That was the biggest difference I saw in my two programs.
Yeah, it's so interesting that you say that because I think it was around 2010 when the Future of Nursing report came out. And there was this really big push and emphasis that all nurses should have a bachelor's
Right.
degree. And they kind of started phasing out some of these diploma programs. My mom and dad were both registered nurses, and they went through an associate degree
Yeah.
track of program. We have a serious nursing shortage right now. Do you feel like that's something that we should be looking at going back to based on your experience?
I think that the associate degree, which is a 2-year degree, was so great to get people, especially like working people that had children and families and couldn't afford to be off for a 4-year stretch before they were making money. It gave them a great way to be, like I said, very good bedside nursing. You can learn those skills in 2 years with the good programs. And in Kansas, where I'm at, we actually have two close to my hometown that are actually the technical degree, like at a tech school that have 2-year programs. They have very good pass rates, their nursing boards, and their nurses come out very well prepared for bedside nursing. So I really think with the shortage, it would be a great way to get some people into the field that would like to, but just simply can't do a 4-year tract.
Yeah, it kind of almost seems like this push for more advanced education, it had a good intention, which was to get more nursing education. But unfortunately, there was that unintended consequence of actually driving nurses away from the bedside. And in your case, like many, you decided to go for a more advanced education. Now, before you did that, what field of nursing were you working in?
When I was a nurse at the time, you couldn't go into the specialty areas without at least a year or two of experience of like med surge or things like that. And I think, again, we're doing a huge disservice to our new nurses by letting them go straight to ICU, straight to ER, straight to OB, which are very high stress areas with high burnout rates. and they go in there with not a lot of knowledge or skill. Not that you don't learn things in nursing school, but we all know that once you get on the job, you learn so much. And that first year of just bedside nursing, learning how to do time management, take care of multiple patients, and get really good at those skills really helps them. So I did med surge for a year, and then I did ICU for a year. And then I did kind of the float pool of ER, ICU, med surge, trying to give myself a really good variety of backgrounds. The other thing I think is concerning is nurses that go straight to office based nursing. Again, not that we don't need that, we absolutely do. But you just don't learn the same things in an office that you do in the hospital setting in terms of critical thinking and seeing really sick patients. And so that's my other concern is we have people going on and getting these advanced degrees that have never worked in a hospital setting.
Yeah, I even think about that as an outpatient family doctor. No, I don't today do the work that I did when I rotated through the hospitals, but what I learned from that, the critical thinking, as you mentioned, but also the serious consequences of what happens when things
Yes.
don't get taken care of, sometimes in the outpatient setting, or to
Right.
be able to explain to a person that I'm doing screening for colon cancer, what it looks like when you really have colon cancer and you're in the hospital, having that opportunity to see all of that those sort of end stage consequences, I think makes you, much more able to manage outpatient situations.
Absolutely. I used to give a talk at the residency that I worked at as a nurse practitioner on how to pick a nurse practitioner, a PA for your practice to the family practice residents. And the one thing I always said is you've got to know their background because if they've only ever been in an office setting, if they've never had any nursing experience in a hospital setting or critical care type of environment, they're just not going to have the same skill set as those that have done that.
I want to hear a little bit more about that because that's an area that we haven't really explored much in these conversations. Right now, there are an awful lot of physicians that work with NPs and PAs and value them. And there are newer ones that never really received a lot of training on how to work together. What kind of advice would you share when you would do those residency talks?
Yeah, I was giving that perspective as an NP. The first thing I would talk about is their education because a lot of them didn't realize what our education was like. And even as an NP, I recognized how superficial our education was. And not that it wasn't good. I'm not saying it wasn't good because the education was designed for what my job was going to be. It was not designed for independent practice as it is now. That's a whole nother topic. But so I talked about that our knowledge was very protocol based, very superficial. So basically, if this, do this. If you see this, do this. So you didn't always understand why you were doing the things you were doing. So I talked about that. And I talked about how even as a nurse practitioner, I had 3 years of nursing experience going into my nurse practitioner training. And I recognized very quickly that I didn't have enough. And I talked to the residents about that. I said, you want to know what their nursing background was because if it's not like myself, that's why I was always very cautious with patients. I always went and grabbed opinions from the residents or the faculty because I knew what I didn't know. And I really understood that very quickly. It became very apparent. So I talked to them about that they needed to know what the nursing background was, what type of nursing they had done. Again, if they'd only ever been an office nurse, probably they would have a very, very limited knowledge base. And not that it wasn't bad. It was just, these might be people that only are going to see well children, only are going to do school physicals, only, just very, very specific type of tasks. That was probably the biggest thing I talked about was understanding their background. Even the PAs, because I had friends that were in PA school as well. And I said, if they went straight from college to PA school, they're going to learn a lot in those 2 years of their PA clinical rotations, but they still don't have the fundamental knowledge base that the physicians do. So understanding those differences in training was a big thing I focused on and experience prior to becoming a nurse practitioner. There was a huge difference between myself, who'd only been a nurse for 3 years, and the other nurse practitioner that I worked with at the time, who had been a nurse for 15 years when she went back and got her NP. Huge difference. And I learned a lot from her as well.
And so interesting now we have up to 22% of current family nurse practitioner students have never even worked one day as a nurse.
Right. And that to me is just it was not what nurse practitioners were designed. It was not what the field was designed as. So that's very, very concerning to me. Also, from what I've heard from friends that I know that are going into these programs, the online programs, everything's 100% online. I don't understand how that can be done.
Yeah, it really doesn't make sense.
Yeah.
So you were working as a nurse, you were rotating through, and then you always had in your mind that you wanted to continue to be a nurse practitioner? Was that when you started with nursing with that in your mind?
Not really. I kinda didn't think about it. Pretty much, I just kinda quickly thought I've always been like a lifelong learner and one of those types of things, and I had always wanted to be a doctor. I really love school too, which is a good and a bad thing. So I just kinda was looking for something else, like a challenge, I guess I would say. And then some of the nurses I worked with kind of talked about it, but none of them were nurse practitioners. They were all bedside nurses, but several of them said, "You're too smart to just stay doing this." That's what they would say, and I look back on that now and I'm like, that really was a they were very smart, very great, good bedside nurses. So that's I think I just kinda wanted a new challenge and just kept going, I guess.
Yeah, it's kind of a shame that there's not
Yeah.
some other path that's encouraged for those nurses that want to do more, but to keep them in that bedside role, and I think
Exactly.
or maybe to teach other nurses if that was more appreciated and more valued. I mean, we know if you go into academics and you teach nursing to nurses, you don't get paid the same as if you go and become a clinician, nurse practitioner, and I just feel like that is one of the fundamental issues that is driving some of this.
Absolutely. Because when I was in my nurse practitioner program, I actually taught for a semester because I was working on my master's, so I was able to teach at our local nursing school a clinical rotation, and I really, really enjoyed it, and I do agree, I think if academic nursing was valued the way it should be, we could have some really great instructors.
So you ended up going to a 2-year brick and mortar master's program at Wichita State University in Kansas.
Mhm.
Talk a little bit about that process.
Yeah, they made it at least it seemed like it was very difficult to get in. The application was tough. You had to, I believe, an essay. There was a cutoff on a GPA, and I don't remember what that was. I'm sure I could find it. You also had to have a minimum. The bare minimum was 2 years. And I actually didn't know if I would get in because I only had 3 years. And they didn't specifically tell you you couldn't work full time, but it was very well understood that you should not work full time. And so I had to figure out how to pay for that and still work some on the weekends and things like that. And then that first year was mostly we did a couple days of clinical in the summer when we started we did not do much clinical that first year. It mostly was classwork, some advanced pathophysiology and advanced pharmacology, and then the rest of it was nursing theory. We had to do like a research project, an actual like a it was a paper. We didn't actually have to do a project, but we had to do like a proposal. And that was what I remember from that first year. The second year, we did like 6 or 8 weeks of clinicals, maybe 3 days a week, maybe four with one nurse practitioner or a physician. And then the rest of that year was classwork, all clinical based, like classwork, different systems basically. And that was 1 or 2 days a week and then 2 days a week of clinical. So 16 hours of clinical for that year. And when you graduated that summer, you did like a 6 or 8 week practicum, they called it. And that was like Monday through Friday, 40 hours a week sort of thing. But all the rotations were set up by ourselves. Wichita State's a big university here in Kansas. My instructor came out one time to my clinical rotation that whole time. So really no oversight. So even with that, I feel like students could have had a pretty poor rotation and still gotten through. As a student, I didn't really think much about I thought it was weird that I was paying all this money and I had to set up my own rotations, but it's just what it was.
It's so interesting that you can just see the variability, and you have someone that's really conscientious and, maybe a little more connected and more
Right.
savvy, figuring those things out and knowing where there may be some gaps and they need to get more experience. And then maybe you have somebody that's just doing the bare minimum. So, did you end up with a lot more than the minimum of 500 clinical hours or so when you graduated, or that was about
No.
it?
No, that was I didn't do any extra, I can honestly say I was fairly young. I think now obviously knowing what I know when I got done, like once I finished and started my job, I wished I would have done a lot more on my own. And my preceptor, who I ended up working with, who had been a nurse for 15 years, she had done a lot extra. And there was a huge difference between her and me, huge. So I learned a lot from her as well. And I also was in a very safe environment job wise. I was surrounded by residents and attending physicians who are always available.
It's so funny because some of the academic experts are calling to increase from 500 hours to 750 hours. And there's been a backlash from some of the NP organizations saying there's just no way that schools can graduate people and get them that many hours. And what a push against just an extra 250 hours, which from
Yeah.
what you're saying, it sounds like would have been quite valuable.
Oh, it would have been like as soon as I started working, I thought, man, I did not do enough.
Yeah, I mean, of course, we're going to get into what it's like to be a physician. And even after
Right.
our hours, we didn't feel like
Right.
it was enough. So what's interesting is that in a number of states, we have independent practice for nurse practitioners in about 27 states, and a certain number of them, I forget how many, but a good number of them, you can start independent practice from day one, meaning you graduate and you're it. Were you in any way prepared to practice independently when you graduated?
Not at all. But I would even say after my 3 years of working, I was definitely much better, but I still should not have been independent. I still struggled to read basic chest x-rays. I mean, unless it was really obvious. And I still struggled, like I wasn't good at suturing. I wasn't good at fracture management. All these things and I actually never moonlighted. I had friends that would go do extra work on weekends in little ERs places and would talk about things. And I was like, I just won't go do that because I was terrified.
It's really unfair to nurse practitioners and to
Yes.
students because you're going through this program and you're being promised that when you come out, you're going to be able to do various things. And then you're expected by your employer to function at the level of
Yes.
somebody that has way, way, way more training. And that's just so unfair.
It is very unfair. It sets them up for failure.
It does, and I guess what we hear is, well, there's on-the-job learning and you'll pick up more, but that's not standardized, and it just depends on who you're working with and who you're
Right.
hired by. There's just so many variables that to me are a recipe for disaster.
Right.
So you graduated from your nurse practitioner program, you passed your certification, you got your first job, and that was working with the residency program?
Uh-huh. I was a nurse practitioner within the residency. That was about 3 years. What's interesting, and I left it out of that, was I did take a little hiatus. Oh, about a year and a half in, I got offered a job with the hospital in our town. To believe this or not, they had an inpatient psych unit to help with to be like the nurse practitioner for that field. And I actually did it for like 6 weeks. And I told them after 6 weeks, I'm like, I don't know what I'm doing because I had never done psych in my ever. And it was quickly apparent, I was like, this is not smart. And so I actually went back to the residency. But I think about that now and I think, how did I think that I could go and do psychiatric nurse practitioner when I had never done psych a day in my life, other than just the stuff that came through a family practice office. That if it was anything more than very basic, I hate to say basic because none of it's basic, but very simple anxiety or situational things, I would always go talk to the faculty. I would never address that on my own.
Right, and you certainly weren't managing bipolar disorder,
No, no,
schizophrenia symptoms, et cetera,
exactly.
psychosis. And what's fascinating is that, I'm sure that when you applied for that position or they recruited you for it, you figured, well, they must think I have the competencies to be able to do that. They wouldn't ask me to fill a role that I'm not
Right,
prepared for.
right.
So that's
Yeah,
on, these employers that we see this all the time advertising their ads where they say we're seeking either a psychiatrist or a psych NP. And it's like, well, there's a big difference.
there's
Like,
a
what are you
huge difference.
asking? What are you asking to be managed here? So, and yet
Right.
these employers have started to view it as, that we're exactly the same. And you're speaking to the fact that absolutely, as a family nurse practitioner, probably even as a psych nurse practitioner, you would not have been equipped to manage those patients.
No, no, not at all.
So what was it that got you interested in going back to medical school?
Well, like I said, I had always wanted to do it. My father died when I was 9, so we spent a lot of time in the hospital. So I was always very fascinated with medicine. And then when I worked at the residency, I thought I was too old to go back. I was like 27, 28 years old. I thought I was too old at that point. Well, then I saw these residents coming through that were older than me. And I kind of started talking to them, and they were like, no, you're not. They basically encouraged me. The residents did. And so I'd say that's what got it going was the residents actually really encouraged me and showed me that I was not too old. So I kind of started to look at the process, and then I quickly realized that I didn't have the sciences I needed to take the MCAT. So I was working full time as a nurse practitioner with 2 children. And luckily, again, I worked at a great place that helped me adjust hours, work around things so I could go back and take the sciences I needed to take the MCAT. And so I took the sciences and then applied and got in. So yeah, it was about a year and a half long of taking extra science classes before I could take the MCAT.
There are some advocates for NP independence that like to equate nursing school to medical school. And I've looked at the nursing school curriculum and they do some biology and I don't think there's physics or organic, but they'll kind of equate it. But would you say that your nursing preparation, we're just talking about the pre-med sciences, were you in any place more prepared because of your nursing school?
No, my nursing classes, so I did have to take biology and a lab, and it was the science for science majors. I took Chem 1 and biology and then microbiology and the A and P, like that all science majors take. And that's the only sciences I took for nursing school.
So then
That
you
was
had
all
to
that was
add on
required.
organic,
Yep.
biochemistry, physics.
Yep.
But
Chem
okay,
2, physics.
let
Mhm.
me ask you this because then they say this, well, why do you need any of those things? How does that really help you to be, quote, provider? Do you have
Yeah.
an answer to that?
Yeah, I absolutely do. Because when I was taking them, I was like, God, why do I have to do all this stuff? But once I got to medical school and did the physiology and the pharmacology, I was like, wow, now I see why organic is so important. So you actually understand how drugs are made and how they work on receptors. The other big thing that I really understood was the physiology and like the biochemistry. That was huge. I was like, oh, now this is all kind of making sense. And then physics, because that was one I was like, why do I need to know physics? Um, was when I started learning about how blood pressure, how our heart actually pumps. Because in nursing, you don't really understand that. You know, the very basic and the flow of the blood and those kind of things. But once I had physics and then I went to medical school and had these classes, I was like, now I understand why physics is so important because that's how all of those processes happen. It's just physics.
Yeah, and definitely it's gonna add if you wanna go into ophthalmology, there's
Absolutely.
optics, and then if you wanna go
Absolutely.
into radiation oncology, now you're really for me as a family doctor, I do sometimes say, like, "Why did I have to go through that
Yes.
torture?" But you are
Sure.
making up the good point that, having that fundamental knowledge, it's a building block and
It's a
everything
building
comes
block. Yeah. And it helps you go back when you're struggling. You can be like, okay, let's think about this, how it all starts. And so it really, like for me, like even when we're doing peripheral nerve blocks, the nurses will be like, why is this so hard to push? And I'm like, it's just simple physics. And that's something as a nurse I would not have known. And it
very
just it
interesting.
just builds on that. Like you said, it's a building block.
So you went back, you did those really hard prereqs, and I remember many sleepless
Yes.
nights and the MCAT and
Yeah.
and all of that, and you got through it. You applied for medical school and you were accepted. How did you feel on that day?
I was really very excited. I kind of get goosebumps still thinking about it. It was just like, wow, this hard work is really paying off. And then I got nervous because I'm like, can I really do it? And the first
Imposter
semester
syndrome.
of medical school, I actually almost quit several times
Really? Talk about
because
that.
it was just so difficult. I had never had to study like that in my life ever. And I thought, man, I gave up this job as a nurse practitioner that was Monday through Friday, 8 to 5. It's for this. It was very humbling. Let's put it that way. That first year was very, very humbling.
Yes, yeah, you took me through a roller coaster of emotions because I was thinking about, my college dorm, receiving my letter of acceptance to medical school, the thrill, what a roller coaster. You're up here and then starting medical school and failing my first gross anatomy exam because I
Yes.
just was totally unprepared for
Yes.
what it was going to be. And for me, quitting was not an option because I just felt like, what else will I do? And I put this
Right.
much into it already. Although in retrospect, that was just one tiny step in a very
Yeah.
long journey. But yeah, I feel that up and then that crashing down where it's like,
Yeah.
"Oh my god, can I do this?"
Yeah. I failed my first biochemistry exam and I never thought I'd recover because I've never
Yeah,
failed an exam in my life.
same, same.
Yeah.
It was heartbreaking.
Yeah.
Fortunately, in my class, we had about 60 or more students that failed that first exam.
Same.
It was so humiliating because at the end of the lecture, and I was kind of shell shocked because I had just seen my grade post and my mind was kind of spinning. And then at the end of the lecture, which I completely zoned out of, the professor said, "Everybody who failed the exam, please remain behind." And then so lots of people get up and leave, and then we're sitting around and looking around, and that was actually good. It was humiliating, but also we realized you weren't alone. And
Right.
then actually made my very best friend in med school that day because she was sitting next to me, and we said, hi, and introduced ourselves. And then we got some tutoring to help us learn how to study
Yep.
properly for the exam. And but wow, what an experience that was.
Yeah, it's an experience.
So you got through that, you got through all of the coursework that really was unique from what you went through in nursing school,
Yeah.
right? There was a lot of courses that you hadn't even touched, and you didn't really know anything about courses like histology, embryology. Did nurse practitioner school give you any advantage, would you say, in med school?
No, not at least not the first 2 years. Initially, I kinda had this attitude that this is gonna be kinda easy for me because I've done a lot of this stuff, and I was, again, quickly humbled. The only part that it helped me the first 2 years was I had heard a lot of these terms. I had heard, at the hospital and in clinic, people talking about stuff, and I knew the diseases, so I had heard some of these diseases before. I didn't always know what they meant. I felt like it helped me was maybe the first full month of clinicals. And like in my medical school, we did like some patient interactions during our first year. And I really shined on those because I wasn't uncomfortable around patients. That it wasn't that I knew more than them, it was that I was comfortable talking to patients, talking to nurses. I was very comfortable in the hospital so I could find my way around. But when we actually started clinicals, everyone caught up to me within about 3 months because it's a quick learning curve. If you don't make it. So they quickly caught up to me in about 3 months.
It's so you got through medical school and then you graduated. And as we all know, you don't get to just start practicing medicine when you graduate from medical school. But I will ask you, if you had been able to just start being a doctor right then, were you prepared?
I would say no. I would say maybe for some basic I don't even I yeah, no, I would not have been. No, I'm trying to think what I would have been comfortable doing all alone, and even
Is,
with my background, I
is
would have
that
still
because
been
you
pretty
just
nervous.
realize that there's still so much that you need to know, or because of
Yeah.
the humility that comes with seeing all the
Yeah.
things that can happen?
Yes. Yes. Yeah.
So, of course, as we all know, you don't get a medical license until you at least do some residency. You chose anesthesiology,
Mhm.
which is 4 years,
It's 4 years, yeah.
which is 4 years of residency. And talk about what that experience was like.
In anesthesia, the first year is your intern year where you do kind of a broad range. You do like an internal medicine residency for that first year. And that was so great because you learned so much in taking care of inpatients, all the outpatient specialties, cardiology, surgery. We did rotations and all of that, which was really incredible. And just learning again, time management, how to manage patients that are very ill. In anesthesia, you're also required to do 6 months of ICU care, and there's certain required ones, but then there's extra you can pick, and I did a month in the PICU, which was invaluable. I just that first year of out of medical school, just the amount of knowledge you gain is incredible. I always say I felt so smart after that intern year.
Yeah, that was a huge learning curve that
Yes.
intern year. And then for me, my first year of practice was also like another
Oh, yeah.
one as well.
Yes.
And you ended up going into pain management.
I do some pain management, but I still do anesthesia as
So
well.
there are some CRNAs now that say, especially their leadership and their lobbying at advocacy groups say that really they can do the exact same thing as an anesthesiologist and that they should be allowed to practice completely independently. Do you have thoughts on that?
I do. Kansas is an opt-out state, so CRNAs in Kansas have been able to practice independently for years, and I work with some amazing CRNAs that are so good. But the same thing as the nurse practitioners, at least the one thing I will say about CRNA training is they have kept it very controlled, which is good. There is no online option for them. They can't work full time and do it at all. Most of the time, most of them do not work because they can't. It's very rigorous. So I do applaud the CRNA programs for maintaining that integrity of their program and not trying to make it easier for everyone to do it because it's a very high risk area and we have to make sure we have good people in there. And even with that protection, just like medical school, we still see people that maybe slip through the cracks that maybe shouldn't be doing it. But I still think the best model for anesthesia is the team model where you have physician led care working side by side with CRNAs, but always having a physician available in case a problem arises. Because anesthesia, they compare it a lot to airplane pilots. Usually it's very straightforward. The takeoff and landing are the hard parts. And you want somebody with the most experience and the most skill when there is a problem because it truly is seconds. You don't have an hour. You have 2 or 3 minutes before you have a hypoxic. brain injury, which is catastrophic. We see it in dentist's office at least 5 or 6 times a year in this country, which is horrifying. That's a never event with a child. And so I still think the team model is best. A lot of people advocate that it helps get people into rural areas if they have CRNA independence. The problem is because of a law called rural pass through, anesthesiologists can't work in rural areas. Even if I wanted to, I can't. The hospital gets more money if I'm not there, if they have a CRNA. And that the ASA has been working on trying to fight this for years and it's never changed. The other issue with CRNAs I have a big problem with is the pain management side of it. In little hospitals across this country, CRNAs are performing procedures that pain fellowship trained physicians are doing. They go for a year-long fellowship, they call it, which it might be a weekend here and there, and some online training. And they're doing radio frequency ablation, spinal cord stimulators, things that I will not even do, even though I have done pain side by side a pain fellowship trained doc for years. But I will not do radio frequency ablation because I recognize how dangerous that is and that that's something that only should be done by a physician that has done a true medical pain fellowship. And that's not the practice of nursing. I feel like if they're going to do that, they need to be held to the same standards and governed by the medical board and not by the nursing board. And so that's probably my biggest issue with CRNAs is I do think we need to be in a team model. And I also don't think they should be doing pain procedures comparable to a pain physician and getting paid at the same rate.
Yeah, it really doesn't make any sense. And
No, it doesn't.
do you think that just maybe patients don't really understand or know the difference if they're going to these clinicians for those kinds of treatments?
I do think that's part of it because the advertising, at least here in Kansas, is very deceptive because they do have their DNP now. So they can say doctor so and so. Patients don't understand that that's not a medical doctor. And I'm not saying they don't have their doctorate degree, but in a healthcare setting, a doctor means one thing and a DNP is another. And I think that's very deceptive to patients. And I think if patients knew the difference or were at least educated on it, then they would at least have a choice of where they went. But the problem is the rural hospitals are trying to survive. And again, I don't begrudge them this because I know that a rural hospital is so important to the communities they're in. They get so much money in facility fees when they do these procedures that it helps keep their facility open. And that's a whole nother topic in that how healthcare is paid for, we need to look at, in my opinion.
Yeah.
Hospitals shouldn't be staying open because they're doing spinal cord stimulators and radio frequency ablation, things like that. They should be staying open because they have beds for patients that are being taken care of.
Right, because then meanwhile, while they're doing those kinds of things, they're closing the lower
Yes,
paid,
paid things.
services like pediatrics or
Absolutely.
obstetrics.
Absolutely.
It's a huge problem. Are you working at all with your state medical society or any kind of legislators to address some of these issues in Kansas?
I'll be quite honest, I was for a while. I actually stopped because where I practice, several of the CRNAs I work with, it became very, I don't want to say bullyish, but it became a very kind of hostile work environment. And the way I was portrayed by the Nurse Anesthesia Society in Kansas was that I was anti CRNA. And we already have a hard enough time recruiting nurse anesthetists to Salina, Kansas, that my group and the hospital, in fact, kind of asked me to not do that. Even though I said nothing negative about CRNAs, I said how valuable they were, but it was taken as I was against them and not supportive of them. And it made it people said people didn't want to come work in Salina because I was anti CRNAs.
Wow.
Yeah. So I actually quit doing that. Yeah, it was pretty awful. It made
I
me know I never wanted to go into politics.
Right. No, I get that totally. And it's so sad to hear that because you're advocating for some reason and
Right.
safety. And you're not the only doctor I've spoken with who's had to silence themselves because they fear repercussions. I interviewed a doctor who was fired for speaking out, just simply identifying the differences in training. And then recently, a friend of mine was let go of a locums job because CRNAs heard them speaking out about the importance of physician-led care teams. So the
Yes,
repercussions, the bullying, these are real and
it's real.
it's a problem.
Yeah, it is a problem. And I will say, like, some of my good friends that are CRNAs that are what I would consider and I mean, uh, my CRNA friend took care of me for my surgery last week. in a physician-led care. My partner was also there.
That's
She's
right.
amazing. She's wonderful. And we need CRNAs, we need AAs, but we need in the role that it was meant for.
Well, thank you so much. Any final words that you'd like to share with the audience?
No, just thank you for having me on and thank you for the work you guys are doing. I'm really glad to be a member of PPP.
I hope you've enjoyed this episode. If you'd like to learn more, then I encourage you to get the books Patients at Risk and the follow up book Imposter Doctors. If you're a physician and you'd like to learn more about getting involved in our mission, which is advocating for physician led care and truth and transparency among healthcare practitioners, please join our group. It's called Physicians for Patient Protection. You can learn more at our website, physiciansforpatientprotection.org. If you'd like to be on the podcast or you have questions or comments, feel free to send me an email through the link at the comments under through the link at the website patientsAtRisk.com. Thanks so much, and we'll see you on the next podcast.